say welcome. This is the second symposium of Let's Talk Clots, which is Thrombosis UK's celebration of World Thrombosis Day. We just had a fantastic first session. We had over 500 attendees and some fairly feisty comments, and I hope people benefited from the excellent speakers, myself excluded. What have I got to say? I am Professor Beverley Hunt. I am a professor on thrombosis and hemostasis, and I'm also founder and now chair of the trustees of Thrombosis UK. Yes, I do have a black eye. It's not domestic violence. I fell over. I'm quite clumsy when I was lecturing in Buenos Aires, and it's taking a while to settle down. And my hip and my shoulder were the same. Let's have a little look. I think the numbers are settling now. This is just to say, if you have to leave, we will be putting this recorded series of talks on the platform soon after, so you'll be able to go back and have a look if you're already registered. And then the last thing to say is Matt Fay's having a bit of difficulty with his firewall, so he's going to go second, and I'm delighted to welcome Dr. Ahmed Talib to talk first on this symposium on diagnosing DVT clinically, just as hard as ever, except not, I suspect, after you have heard from Dr. Ahmed Talib. So he's a GP with expertise in DVT assessment and treatment across the entire healthcare pathways. He's in primary care, but he's worked in clinics and hospital and the emergency department and even hematology wards. And his leadership roles have led him to develop improvements in acute illness services and service pathways for vascular and cardiac care. And he's really quite passionate about improving clinical outcomes. So I'm going to hand over to him to tell you about some exciting developments. Ahmed, over to you.
Good morning. Thank you so much for the introduction. And as Professor Beverley spoke, I'm quite passionate about thrombosis and DVT management and trying to improve patient outcomes and pathway. So the first thing I wanted to mention before we dive right in, as you guys know, DVT can present in quite wide of symptom ranges. So when it presents to GPs, it can be a bit tricky. It's not obvious straightforward because it can often overlap with other conditions. There's often time constraints in consultations. In general practice and primary care, you often have around 10 minutes of consultation, which sometimes leads to misdiagnostic opportunity. Furthermore, blood testing is often delayed and results are often delayed as for example, D-dimer testing. There's often constraints with diagnostics because the only way to diagnose DVT or exclude DVT confidently is by doing ultrasound, which is the only current availability is secondary care by referring to the patient to secondary care. And often there's a lack of follow-up with patients because of that. And most of these patients do not have DVT. So that's why we have worked with ThinkSono to try to find a solution. And ThinkSono is basically the world's first company which have developed the first software in the world to do a blood clot detection, which I wanted to talk about today. So as you guys know, blood clots is a major global burden of disease. It leads to there's more people dying from DVTs than breast cancer, AIDS, and car accident combined. And that's why it's really quite relevant. Let's have a look here. So the most important bit is this bit. So we built the first software to develop blood clots, i.e. deviate thrombosis. As I mentioned, it's because it's one of the most important preventable deaths in the world. The incidence is actually surprisingly high. So currently in primary care, around 3 to 4% of presentations is actually a potential missed DVT. And that's why this is even more important. So in the slide here, we can see the software we have developed, which is basically a quite simple software. It goes into your smart phone, iPhone, so either Android or Apple iPhone, and it connects wirelessly to an ultrasound device, which you can see here in the picture. And that device, you can actually scan the patient, and it uploads the images wirelessly to a cloud dashboard, which the radiologist or the sonographer can access remotely. I'll go into more details about it in a few minutes. This is actually the important bit to see, because what our software does. So if you see here, I get to press the play to show exactly what happens. So what happens here, the AI guidance helps the person doing the scan to show them where to put the prop correctly. And it actually tells you to adjust where to put it if you're putting it incorrectly. And it automatically detects the right spot for you and tells you to compress in that correct spot. And it tells you if the veins are compressible or not. As we know, it's compressible, so the DVT, if it's compressible. And then what happens is you upload the scan to the cloud, and it goes to the radiologist in the hospital to diagnose. And the whole thing takes around minutes. So this is what the key bit of our technology. So the key bit here is that the fact with minimal training, with 1 hour training, our technology can teach a person who's a nurse, a HCA, basically a person who's not trained in ultrasonography to perform the scan confidently and correctly. And it goes to the cloud. And we are the world's first ultrasound AI company in the world who actually obtained CE checkmark and EU approval. To go through more, and we're actually also working in the States, where we're doing multiple trials in the States as well. And Dr. Glenn Jankovic, which is the Chief Division of Vascular Surgery in NYU, has been quite impressed by our technology and sees the potential future with us. It's quite enormous. We obviously been working in the UK as well over the last several years. We have done 7 trials, 5 trials which have been double-blinded trials in 11 hospitals. And we have scanned so far around 500 patients in secondary care. And these are the trusts that we have worked with to do these trials. And we have done an additional 500 patient trial, which is a primary care trial, where basically patients presented in primary care and was scanned by HCAs in primary care. And this was done with Care UK and is due to be published soon. We work with other partners, which is the Butterfly Probe and Scan Labs, to connect our software to the wireless ultrasonography, the portable one. And obviously more are coming in the future as well. And we are a company that is very strongly peer-reviewed. All our trials are published and peer-reviewed. And every trial we have done is actually also published in our website, which is thinksonar.com. So we have all the details of our trials there. And this is the most important slides for everyone to look into. When we looked at the evidence, because that's the most important bit, can we, as a company, create a device that does scanning, which is as good, as comparable to current gold standard ultrasound? And when we compared it, when we pulled our ThinkSonar sensitivity with the pool sensitivity of a meta-analysis done by Bat and colleagues, we can see here it's quite similar. So ThinkSonar is 90.2, and the pooled analysis from meta-analysis done is 90.1, that's the most important bit, because with our scan, you can confidently exclude DVT. Our pooled specificity is actually slightly lower, but there's quite a lot of reasons for that. The reasons for that is because we use our device as exclusionary rather than purely diagnostic. So we use it to exclude DVTs, which is the majority of patients. 90% of patients presenting with suspected DVT don't have a DVT. And also because in the analysis, we asked always our the people who were assessing our scans to always refer any scan they were not sure about or suspecting even slightly. So that's why the specificity is slightly lower. This obviously will correct more and more the more data we have. But the key thing here is the sensitivity, as i.e. with our scan, you can confidently exclude a DVT. We have also one of the few companies which actually published a full health economics study, which was published in Nature, and we can show that there's a cost savings, amount of cost savings between 72 to 108 pounds per scan done. So it will save money for primary care, for secondary care, and the NHS overall. So actually, by using that approach, you save a lot of money. And this is one of the really important studies, which is going to be published shortly, which is the primary care study, which is a point-of-care ultrasound used to primary care to reduce the referral rate of DVT patients to hospital. And we obviously were awaiting the full data analysis, but so far the data analysis seems to be the same, that the outcomes, the sensitivity is as equal as I've explained earlier. And this is our studies, which is being started in the States. We are currently working with Temple Health and NIOU, because we work with FDA approval as well, which is the next stage we're doing right now. The reason we all have worked on all of this, and the reason my passion for this is the current pathway is horrendous for patients. So currently, when I see patients for suspected DVT in primary care, I'll make a referral to the AMU or SDIC or emergency care, which will take several hours for the patient to go there. By the time they go there, they have their assessment, which takes again several hours. By the time they have the dimer, and they may or may not have the scan. Very often, patients don't even have the scan that first day. They often get rebooked for a subsequent day or a third day to come back later, and they get unnecessary anticoagulation if they didn't have a clot. Furthermore, what happens is this is within hours. So you can imagine if it's out hours. Out hours, all of them have to go to emergency department, and they will not get scanned. And they need to come the subsequent day again. And this is high cost, highly distressing for patients. And if you think about it, there's another subset of patients, which is, for example, elderly patients, dementia patients, housebound patients, patients in nursing homes. These are all unfit to have this current pathway, which makes it even more complicated. While with our software, it's very simple. The patient has suspected DVT. Any nurse or HCA with a training of 1 hour can do the scan. It can be done in any setting. So what I mean, primary care setting, which is the Care UK study, which is focused on. It can be done in nursing home. It can be done in A&E. It can be done in DVT clinic. And scan is sent remotely to the radiologist, and he can report it within 20 minutes. And you have an outcome very quickly. So this is both dramatically changes the entire pathway for patients, increasing satisfaction, accurate diagnostics, and you also you actually end up following the current guidelines, which is the current guidelines says from suspicion of DVT to scanning should be within 4 hours, which unfortunately now having worked for 15 years in multiple settings, very rarely seen that happening, where patients actually get from suspicion to scanning within 4 hours. So this is examples of implementation we have shown. So the implementation the patient can be seen either remotely, like I said, in primary care setting, having the scan done. And if the scan is negative, they can come back for 6 to 8 days to have another scan to double check the fact that it is still negative. Or they can have a D-dimer plus a scan. And if both are negative, they get discharged. Or they can have a scan, and if it's suspicion for a DVT, then they go for a full ultrasound. So there's different solutions for this. The key thing here is that the vast majority of patients, 90%, who has negative scans, don't need further investigations. And then what the secondary care can focus on, these 10% of patients who has the suspected DVT, who has what looks like a potential DVT, and focus on them and diagnose them and treat them further. So we're hoping this gave an overview of what our company is doing and what we're hoping to do. And we're hoping this was helpful information to everyone.
Thank you very much. That was clear. I think there is a question in the chat saying, oh, but they were going to pick up distal DVT and NICE says not to treat them, so we may overdiagnose. But could you just go through again the points that you are looking at with your ultrasound? Because I seem to remember it wasn't below the knee.
Exactly. So I forgot to mention that. That's a really important point because we don't treat distal DVTs, and that's why our current method is actually looking at proximal DVTs. That's actually a very good question and really important one. And it is an interesting one because some patients ask us why we're not doing a full leg scan, but we're saying it's because NICE guidelines actually says we should follow in the proximal one. But that's an excellent question and an excellent point.
So I think that makes it very clear. And, you know, when we look at what we request in ultrasound departments, most follow NICE guidance and will only do the points, the popliteal, and not in the calf because it's not cost effective to look in the calf and you can pick up false positives. So that's what we are doing in the UK at the moment. I know there are some hospitals where they've decided to look below the knee. And of course, in ultrasound departments, we're only getting about a 5% positive rate of DVTs when we send people for ultrasounds. And so if we used your equipment, we would be able to exclude so many more. We would perhaps, I mean, everyone's going to use it differently, I would imagine. But I mean, how I'd like to use it, if it's positive, then you treat your patient and then you perhaps do a backup ultrasound in your own department until you're comfortable that what you're seeing
That's the
with
recommendation we
your
have.
device. That's what you're recommending for now.
Yeah, that's the actual recommendation
And
we have for now as well.
that's hugely cost effective if it can stop patients going on anticoagulation until they have a scan and they won't need to have that second visit. We've got some more questions here. Can I ask you, how much does it cost, please?
So the cost is, we have different models for the costing, but it will be quite cost effective. So what I mean is, when we looked at it, like I said, that we have actually one of the few companies who have done a full cost analysis. And my understanding, it's if you're going to be conservative, the minimum you will save per scan is £72. So, and that's actually what we charge over year. So the licensing, if you do 10,000 patients, is around 7,000 to my understanding. So no matter what, you're going to save quite a lot of money.
Oh, so when you say you're saving for the scans that you don't do,
Yeah.
is £72. So you're saving there, but you're going to be charging £72 if you do the scan.
So I can actually send a more detailed if they send me like
You've got a huge audience here. Is there any chance you could tell them a little bit more about the costing model? Because we'll all be going back and saying to our powers that be, this is going to be good. And I presume you're going to take it to NICE, and NICE will say it's cost effective, hopefully.
Absolutely. So let me show you the actual slide because I want to show it to you in details to really show it to you. Give me 1 second. So because it's really helpful. So you know, see exactly what I mean.
And then there's okay, great.
Yeah. So in our model is because we can see here the offer of the single year license based on 72 per software supported examination. So the licensing fee will for 1,000 patients will be £72,000, you know, and using that model, you will save around 70 to 200 per scan. I mean, per scan. So you'll save that by using that model, you know. And this is a publication we made in Nature, is peer reviewed. So it's if you're using our model, even though with a licensing fee of 70,000 per year for 1,000 patients, you will actually be saving your trust at a minimum £72 per patient. You know, that's including
Okay,
all the
and that's based on the fact you're not prescribing a DOAC,
yeah,
you're not sending them for the scan.
yeah.
You've got the answer there and then, and most of them are going to be negative. Okay, that's very
So that's
good.
the most conservative method. What we
Okay,
actually can be up to £208 per patient. So being very
okay,
conservative, the minimum you'll save per patient is 72 pounds.
okay.
And
Now,
with paying our fees still.
okay, lovely question here. Do you have to wait for the radiologist's opinion for diagnosis, or can the user diagnose?
So the scan will go to the radiologist immediately when it's done, and it takes the radiologist around 15 to 20 minutes to respond, and they can be actually even quicker. You
So
do,
this is your radiologist talking to your cloud,
yeah,
and they could be anywhere in the world. They could be sitting in India, and they get the scan from somebody who's been scanned in Dartford, and they'll look at it and send the reply back. But if you really do see a clot, you could probably get on and start
absolutely. Yeah, you can get an
prescribing
answer.
the treatment and
Yeah.
get the care
Yeah, you can
sorted.
get an answer fairly quickly, and you can get treatment. You can start the treatment pretty much immediately. Not only that, with the way we have done it is that the person who's doing the getting the scan, they actually can answer the results in the phone right away, and they get a text message to their phone saying, "A scan be performed. It's in the cloud now. Please report it." And not only that, the radiologist can also contact you back saying, "One of the spots, can you rescan it again?" So you can get a very quick feedback by
Dialogue
saving
going.
refer
Yeah.
back. Yeah.
Okay. And there's another question. What is the cost of the probe?
The prop doesn't cost you anything. This was something we supply. So we supply everything. The training, this costs £72,000 for 1,000 patients. Is that for everything? You know, for the probe, for the training, for the tech support, everything that it involves everything.
Okay, and we've got some really smart people on the call here because they're asking about what's next, really. So, do you always need the radiologist to be available to read the ultrasound, or can you not train some AI to read it? Might you reach a point where AI will give you the answer?
That's probably the future. And
Yeah.
there's some thoughts about that, but the problem is the conclusions has been it's better to have a human diagnose that. That's the whole, like when we've gone back and forth a lot with that, always been for DVT specifically, it's better to have it, you know?
Okay.
Uh, uh,
That's always the answer with AI. I'm sorry, I'm a bit of a cynic about some of the AI because you have to have a human to check the
that's it. That is
AI.
it.
Okay, fabulous. Right. There's the last one is so the radiographer only looks at the positive results,
No,
and
they look at everything. Yeah, they
no,
look at
I think they're talking about we might just send on the positive results with their treatment to the hospital radiology department or wherever.
absolutely, absolutely. So
Yeah.
that's why we think we will get a lot of support from radiologists because here, in the end, the things that going to go to the radiologist and going to have needing full scans is will be patients who are what seems to be positive, you know?
Okay.
Yeah.
Right. Well, oh, look at this one. This is good. Aziz Farzani, I think, I can't quite read. Has any strong proof been put in place for confidentiality of patient images sent to the cloud?
Absolutely. So we have pretty much every certificate you can think about. I mean, and we regularly audited, and with HMRA registration, and obviously we wouldn't bring this to the NHS because they have very strong confidentiality requirements. EU, I mean, so it matches all the confidentiality requirements for every country we're being in contact with.
Okay, and you have cybersecurity, I presume.
Absolutely, absolutely, absolutely.
Okay,
And,
all
and
right.
believe it or not, that's actually the easier bit. I mean, that's sound.
Okay.
Yeah.
Well, thank you. You've taken quite a lot of interrogation, and we've got some smart cookies in the audience. So I think we've discussed all aspects of your new diagnostic probe. So look forward to seeing it being used in quite a lot of hospitals. Thank you very much for coming today. I hope you'll stay around whilst Matt talks. Thank you. So now it's time to move on to Dr. Matt Fay, who's been a long-standing trustee of Thrombosis UK and currently leading on a significant work program where we're looking at what's happening in the community and how DVTs are presenting. It's called VT Detect. We're just analysing at the moment. But Matt is also a GP. He specialises in cardiovascular health. And recently, he's been part of establishing a super practice called Affinity Health, based in Bradford, which is managing 8 GP contracts and providing care for 64,000 people. He was the clinical lead of the redesign of the Bradford VTE service to make it completely community and DOAC based. And he's previously worked in Bradford PCTs and CCGs. So really, he is a master at managing VTE and absolutely the person to answer this question, why practitioners might struggle with VTE in primary care. Thanks, Matt.
Very much, and thank you for the invitation. Beverley, can I just check that you can see my slides, because there was a bit of tech issue earlier?
Gorgeous.
Fantastic, thank you. So just quickly, my declarations. I just want to highlight, as we go through this talk, we're going to get into a very, very doctor money focused attitude. But let's not forget that the reason we're all here is about the patients. You know, the VT is a devastating diagnosis. Often the people who are talking to us at Thrombosis UK are the people left behind by this diagnosis. So we need to work out how we're going to deal with thrombosis within our hospitals and within our practices. And I hope I'm going to give a slightly different view from the one I gave last year. I focused on one particular paper that I found in one of the insurance magazines, which I think may focus our minds a little. So why are we all talking about thrombosis in the NHS? And those of you who work within the NHS, and I know we've got an international audience here, will know NHS Resolution. NHS Resolution are the people who deal with the financial outcome of complaints. So how much this actually costs the NHS, not in getting the diagnosis right, but when we get the diagnosis wrong or we delay steps along the way. And they did a lovely report a couple of years ago pointing out how many claims come to their department around VTE and the immense amount of money. And the NHS hasn't got many pennies at the minute. And so how it can look after itself and its costing is really important. So the NHS is focused on VTE. We'd like to say purely from a patient perspective, but also because we get it wrong, not in considerable amounts of time, and that getting it wrong leads to issues within our finances as well. Now, I use this piece of information a lot, which is around the idea that it is hard to diagnose a PE. I mean, nobody should say that this is a simple thing to do. But what we are aware of is that, of course, a great number of people who go on to die from massive PE have actually seen their primary care clinician or their major clinician within the weeks prior to the event. And using that beautiful instrument of medicine, the retrospectoscope, we look back at those records and we think, well, actually, we could see that that was a potential diagnosis. So why are we slipping up around this. Now, I'm not going to talk for our colleagues in the hospital. I'm going to talk for my colleagues in primary care. And the first thing we should think about is what is happening in general practice. So if you were to read the newspapers in the UK, you would think that I spend my time on the golf course. I pop in, see a couple of patients, mainly on the phone, and that's my role in general practice. And it's a nice life. I wish that was true. We may be able to recruit more people into the post if that was true. But if we look at what the King's Fund is saying, as a bit of a more objective view of general practice, what we find is that actually the NHS across its spectrum of access points is under a great deal of strain. There is a lot of people coming through the system. And where do those people generally get seen? Now, of course, was going to say this, it's general practice. So of all the appointments within the NHS, the vast majority are in general practice. So within a year, we have about 350 million contacts with patients in general practice. Now, of course, some of that is doing our flu campaigns and monitoring long-term health, but there is a considerable amount of work coming through our buildings. And so you could say, well, maybe we can understand how things can be missed. But the other thing that comes up a lot is, it's because the GP doesn't see anybody anymore. They do all their work on the telephone. So if we're not seeing people, how can we possibly pick up on the nuances of cancer diagnosis or VTE diagnosis? And again, we look at what we're being told there. And again, this is from the King's Fund. And what we find is actually we hit a peak of telephone consultation during COVID, where, yes, it got to about 50%. I think there's a risk benefit there, wondering about bringing people into a crowded waiting room at the time we're dealing with a global pandemic. But what you can see is that is regressing again. And we are seeing many more people in a face-to-face setting. And what does that look like within the practice? And what you find when we look to NHS Digital, who counts everything within the activity of the NHS, is that we find that a lot of those routine appointments are literally that, people coming for a checkup with the GP, they're coming to discuss their ongoing health issues. And that makes up about a third of our work. But actually, what makes up another quarter of our work is actually the acute presentations. So we spend a lot of our time in acute practice seeing people who have got acute issues that are presenting 24, 36 hours prior to their attendance. So we do a lot of acute work. But then the downside of that, we're actually losing our workforce. So we've got a lot of work going on. We can see that work is increasing. And despite the complaints, we're actually doing a lot of this in the traditional old-fashioned way of seeing people face to face. But actually, that's with a reducing workforce. So we do have issues about how we can continue this level of practice. And I'm not doing aren't GPs hard done by. All parts of the NHS is hard done by. But it's just giving you an idea of the pressure that's actually currently out there in general practice. So if we look at why people come to see their GP, what's the major reason? Most people, like myself, hypertensive, and I need assistance in my hypertension management. And maybe we could do something about that and get those seen by people who probably do it better. Trained pharmacists, advanced nurses. So maybe we could change the workload in general practice, but a lot of people come for hypertension. But then it's the coughs, the colds, the shortness of breath, and the symptoms of pulmonary embolism. And so we're seeing a lot of people. I mean, when you consider the numbers I've just given you, and this is 15% of consultations are respiratory symptoms. That's a lot of work, and most of that is not going to be a thrombotic event. So then what should we do with them? And of course, we should look to our pathways of care. We're always being given more and more and more pathways of care, because if we can do it systematically, hopefully that means for the majority of people, spot the problem and the diagnosis. And this is the NICE guidance lifted from their most recent publication. And what we see is that you've suspected your DVT or thrombosis, and then you come down this lovely algorithm. I'm just going to highlight that you actually have to have thought about it. So this isn't a what do you do with somebody who comes in with breathlessness, chest pain, swollen leg. This is what do you do when you have already considered thrombosis as the diagnosis. So we have to think about thrombosis before we even start. So when I'm thinking about people with chest pain, they come in, they've got that tight band around their chest, it's radiating up into their neck and their arms, and I'm thinking this is a heart attack or really horrible indigestion. And of course, I've got that for pulmonary embolism. Well, no, sorry, I haven't got that for pulmonary embolism. I haven't got this classical presentation where I'm going to catch the majority of people. If I can just focus in on a couple of symptoms, I've not got a situation where I can see that. So if we just look at breathlessness, of all those people who present with PE, 50% are breathless, but 50% aren't. So, it is difficult to try and work our way through this, but we have to think about thrombosis. Now, I've talked on this topic several times, and I thought I'd look in a different direction on this occasion. So I thought, what do the insurance companies think about this? Now, the MDU is one of the indemnity companies within the UK. Every year they send out, like the MPS, they send out their journal that you sit down with a stiff drink and read through how many times you've probably just missed the bullet as you read through the various cases that they have. Now, they did quite a nice review a few years ago looking at cases that have come to them. So remember, the baseline here are complaints, are people who are litigating. So some of the numbers here are going to be distorted, but it gives you an idea of what NHS resolution may be looking at and how they may be looking at the system, because it's a difficult diagnosis. So of all the PEs that presented within the year of observation in this study, what we find is actually the vast majority are in hours. So we're looking actually at GPs working in their normal environment. In fact, of all the claims coming against the MDU for PE, the vast majority of them were general practice in-hour consultations. When we look to the symptoms and signs, some of them had shortness of breath. Great. A lot of people in general practice have shortness of breath. A lot of people who come in have chest pain and cough. And what we also notice, of course, is that there are actually 10% that have no typical symptoms at all. So how are we supposed to try and spot these people? When we look, we see almost that same division of people who the various symptoms that we've seen from the previous study. What we also start to see here, though, of course, is this idea that the person with a PE might be tachycardic. Well, they might, but actually 3/4 of them aren't. So where are our signs that we can go to? If the symptoms are so vague, have we got good signs that we can point to? And the answer to that, unfortunately, is no. What's the differential diagnosis? Chest infection. Now, I'm going to actually suggest that I'm taking into account the presentation we've just heard. Part of the problem here is that you've got 600 seconds for this patient. That's a 10-minute consultation. And if your pathway of moving this person down a VTE pathway is complicated and is going to take considerable time for the practitioner in primary care to access, then little clicks are going to go in the brain to say, well, if I say this is a chest infection, I can do that in 600 seconds. If I say this is a VTE, that's going to take me half a day. So we have to think about this within the context of how quickly we can actually work ourselves onto a better pathway. But I'm sure that nobody in the audience, when they consider pulmonary embolism, are surprised about the working diagnosis that these litigative cases show us. Of all the patients who come into this situation, only 2 were admitted to hospital, and 1 of them had an MI. So again, or 1 of them was thought to have an MI. So we're not handing people on very well. Now, again, this is a litigation study. A lot of people died. And of course, that's a good reason to litigate. But what conclusions should we put? And one of the major things that they seem to highlight is that we didn't think of the risk factors. Often we didn't report the oxygen saturation. How do we know if somebody's going to have a PE if we don't think about oxygen saturation? So they're actually suggesting that we are making errors. And they went on to have a look at this in a bit more detail with a respiratory physician showing them the way, saying it's difficult, and we accept that it's difficult. However, we could look in a slightly different way. Make sure we're documenting the vital signs, because this is going to show us a direction of travel. Maybe we should look at the risk factors more. Not only the Wells score, and I'll talk about that in a moment, but if we consider the overall risk the same way that if somebody came in with that central chest pain, yet they're slim, never smoked, no family history, their cholesterol's fine, you take into account these risk factors. Maybe we should be looking to VTE in a similar pattern and saying, maybe we should look at the risk factors. And if you do consider the risk factors, document them. Because actually the minority of people in this study had documented risk factors to suggest that you'd even considered VTE. And then, of course, the absence of chest signs. Now, that's naturally not uncommon in pulmonary embolism, that people have nothing to hear in the chest. But if you're going to diagnose an exacerbation of COPD, if you're going to suggest that this is a chest infection, then you should be eliciting signs. So if the chest is clear, you should be thinking more to the fact that this breathlessness might be VTE, rather than it could be a community-acquired significant chest infection requiring antibiotics. And we're not even going to start talking about the need for aggressive antibiotic surveillance and reduction. So we come back to the fact that what we need GPs who are thinking about it. And this was published a few years ago. And of course, what it is that idea that if you're an experienced GP and you think, I can't work out what this is, it's possibly a PE. That gestalt, I think I know what's going on here. And again, we need our colleagues in secondary care to accept that occasionally I'm not going to be able to point you to a load of great symptoms and signs. I'm just going to give you that gut feeling that I know that this could be a PE. And whether you accept that from the GPR, I think is a question. Whether you accept it from the senior partner who may have had several PEs go under their care and seen the fatal outcome of PEs, I think we need to think about the experience of the clinician who's referring to us. Another problem in general practice when it's looked at from the outside is the fact that we tend to use time to our advantage. So we do see things repeatedly to try and weed our way through. So it's not just 600 seconds. We could have half an hour, but that half an hour is scattered over 3 appointments. But what we do know is that there are problems in getting to a diagnosis and getting to that diagnosis quickly, where it may take me a few consultations to diagnose somebody's palpitations. Usually I've got time to do that. In VTE, and particularly in pulmonary embolism, I often don't have the gift of time. So I need to think about ways of getting through that. Now let's have a look at pathways again. So this is lifted from the web. This is a nice pathway of care. Of course, there, right in the heart of it, as always in an ED department, is the heart attack. It's a common killer. But in this case, they actually do have pulmonary embolism as an alternative. So they actually do step their way through from a good history into looking for VT. And maybe we need to have that kind of attitude within general practice as well. If you think about the possible diagnosis, then you can think about how you might get to a diagnosis. Now, one of the things that are important and was important in the MDU work was the idea of looking at risk factors. So if we consider the risk factors that a patient is carrying, or if we could get the actual clinical systems general practice users to look for those risk factors and flag them to the GP to say, do you know that this person's at risk of thrombosis? Maybe you should consider that in your diagnosis. Maybe these are ways forward. And of course, there's more risk factors, but I am talking to an expert audience. So if we think about thrombosis, what should we do next? Of course, we need to do the risk score. And what we find in some of the complaints and discussions that patients have coming to Thrombosis UK is that they did this fancy score and I was low risk. So I wasn't forwarded onto the hospital. I wasn't put onto a VT pathway because apparently my score was 1 or less in DVT, or in PE, of course, less than 4. And of course, that's not how these scores should be used. The Wells score is not there to determine if somebody has or hasn't got a VT event. It's about how we may stratify their investigation. And what NICE says is if you've got these low scores, then you should go on to have a D-dimer, a simple test. So you're a relatively low risk individual, but there are signs, or there is just that gut feeling to suggest that you may have a VT event. Well, do another test to look for that. And of course, we're going to get the false positives and the people who need to be further investigated, even though they're not going to have a VT event. But isn't that better than sending them away with nothing at all? It says exactly the same for PE. But then it goes on to look at D-dimer testing in a bit more detail. And again, thinking back to that session that we've just had, what does NICE say about D-dimer? It says, well, we think it's a good idea. What they also say is that if you look at it in the context of DVT and putting point of care D-dimer into practices, so they've got easy access to a simple test using a technique that they're already using for glucose assessment and for anticoagulation assessment. So it's not a new technique that they have to learn, that actually it's cost effective to do D-dimer in primary care with a point of care device. And when they looked at PE, it was even more cost effective. So we need to think about within our clinical system, within our clinical environments and communities, how can we get this test close to the patient? And what should that test be? If we're going to worry about the false positives, then we need to think about the fact that this is a test that is not fantastic. It does have issues, but it also climbs with age. So using the same cutoffs for a 20-year-old as we use for an 80-year-old doesn't work very well if we're trying to make cost-effective pathways. So if we thought about it, the low risk and a D-dimer is undertaken, we need to think about how that could be age adjusted. And you could come up with a simple pathway like this that works across primary care. This is taken a chunk out of the work that we did with Sam Aykroyd and Mark Conn in Bradford to develop the community pathway in the Bradford environment, which still runs and runs very effectively. So we can put all this together. The question is, how do we get people onto that first step where you're suspicious that they've got a VTE? Now, Thrombosis UK is not lying back about this. So we're doing some work here. And what we're doing is that we've been auditing general practice. Now, this has been very much coordinated by our chief exec, Jo Jerome. And she went out onto social media and said, asked practices, please put yourself forward so we could audit this. Now, we were going to make it as light touch as possible so the practices themselves had to do virtually no work except from let our audit company have access to their clinical system so they could do the audit. And we managed to get about a capitation of about 400,000 patients. So we did get a lot of patients with PE. Now, as Beverley's already said, we're currently taking this data and having a look at it and try number crunching to get to our publication. But what we found already is that actually a lot of what general practice does is done in general practice. We're not just sending it to A&E. We're not expecting the patients to go to A&E. And this is just one example of what the reports look like. What we do find is, as we already knew, there are a considerable number of patients who take more than one appointment for the GP or the primary care team to work out what might be going on. Those classical symptoms, you need to have that unilateral swollen leg. Well, actually, we're not seeing that all the time, actually. We're not seeing that a lot, to be honest. A lot of what is documented is just essentially the GP having a clinical suspicion. This is all about what the GPs are documenting. Vital statistics, we're terrible. We are terrible at doing this. So, you know, if this did get to the MDU or NHS resolution, they're going to hold their head in their hands and say, well, why didn't you document the heart rate? How can you say that that swollen leg wasn't causing a PE if you've not done an oxygen saturation to see if it's already embolized? So we need to help our GP colleagues do that. And we look to the risk factors and we find that they seem to give us information as well, particularly those ones well known to us. So obesity, pregnancy, recent hospitalization, you know, we cannot get over the importance of that. And when it comes to those risk scores we talked about earlier, are we seeing them used? Not very much at all. So most places aren't looking to Wells PE at all. And this example of a practice down in the south of England shows that actually most of the patients didn't have a Wells score, even though an entry point to many pathways around the country is that in the hospital is that you've done a Wells score. But even then, we see that many people don't have that documented. So what are we going to do with this data? Well, as Beverley has said, we're working to get this published. We're also thinking about what are the next steps. So developing a tool to flag that question of, if you're seeing people in the acute clinic, have you thought about thrombosis? Are you going to document this properly? Get the heart rate, the blood pressure, the temperature, the oxygen sats into the note. Do a weight. Frequently, the BMI in GP records is years out of date. So how do you know if this person's carrying the risk factor of obesity, which we see so commonly in those positive cases, if you've not weighed the person? Yeah, so make sure that we're getting a system, and that flags to the GP. And we're already working with Chris Gale's team at Leeds, who developed the Find AF Lite tool, which does this for atrial fibrillation. And use the patient. If you don't think it's PE or a DVT, when you first see the patient, give them the reasons to come back. Give them the reasons to not come back to you, but to go somewhere acutely. To make sure you safety net your patients well enough. Otherwise, they will cause problems. So in summary, we know there's a lot of bad education out there. We know that people don't have to have a big red leg to have a DVT, but we're still teaching that to our junior doctors. If you don't think about the diagnosis, you can't use a pathway. Think about how you're going to get point of care DDAM as close to the patient as possible, but always keep the pathway simple. Try and keep the interventions for like GPs, generalists like myself, simple, and always make sure the patient knows what's happening to you. Thank you very much.
Well, thank you, Matt. That was fairly awesome. It really made, I think, everyone think about how hard life is in general practice. I just wanted to pull up on one issue. You kept saying a swollen leg, think of a DVT, and just that is a difficult one for me. We know and we hear from our patients who come to Thrombosis UK that they never had a swollen leg, and that actually we know from stats and hospital that 80% of DVT are clinically silent in that they don't have a swollen leg and they might just have pain. And that's just not widely known. It just isn't. And we, people say, well, they wouldn't see me in the emergency department. I didn't have a swollen leg. They said it couldn't possibly be a DVT. So we do have to educate people more about the amazing range of ways that VTE can present.
Absolutely agree. I think the same way we have taught and we've relentlessly taught the clinicians to think about vascular disease in terms of the presenting symptoms, but the risk that the patient carries, I think we need to start moving VTE into that same domain. We all know that heart attacks can be quite silent, but they're not silent in people without risk factors. So we need to carry that conversation across, because the risk factors are, like with vascular, arterial disease, are there and are predictable.
And you really made it very clear how hard it is diagnostically. I mean, looking for risk factors, well, actually 60% of the population are overweight, aren't they?
Yeah.
So yeah, that's a risk factor, but many people won't necessarily have VT. Anyway, thank you. That was absolutely marvelous. There's some praise for you in the chat. I think I'm going to bring this to a close as you've stunned everybody. There are no more questions. Thank you to both the speakers for a fabulous set of lectures. And I warmly invite all the attendees to attend tomorrow as well. We've got a plenary lecture from Andrew Cohen about the future of anticoagulation. Hopefully that will pull in the crowds. So thank you all very much. Thank you, Matt. Thank you, Ahmed. See you all soon. Bye-bye.